over to you, Dr. Chandru, for the first presentation.
Thank you, Dr. Surgeon. So I think my slides are visible.
Yes.
I'm audible, right? Thank you.
Yeah. Make it full
So,
screen, sir.
Yeah,
Just,
done that. Right?
Yeah. Oh, that's okay. Okay.
Great. So my task today is to speak on optimizing treatment strategies in neoadjuvant treatment in the management of HER2 positive early breast cancer. So without wasting time, I'll just proceed forward. And this presentation was provided by Roche, and this is how we have evolved in a HER2 positive breast cancer scenario, where it's a biologically complex disease. So today, when you talk of HER2 positive disease, so we have HER2 new 3+ by IHC or HER2 new positive by ISH, and we talk of either hormone positive, hormone negative with the HER2 positivity. So if you go to the cell line features, so we have various mRNA, microRNA, proteins, DNA copy numbers, methylation, DNA mutations. So those would harbor the prognosis in patients who have HER2 positive disease. And we also talk of tumor infiltrating new lymphocytes, more so in triple negative or not, and also in HER2 positive disease. This is how the neoadjuvant therapy has evolved in patients with the HER2 positive disease. Then we had only chemotherapy and endocrine therapy, and there the aim was to reduce it to an inoperable to an operable stage. Now it's completely different. So what we has transcended with the advent of Trastuzumab in HER2 positive setting has changed the gears into a curative approach and approach the HER2 positive patients more not only from the response point of view, but from the point of survival and better survival. So that's how the aim has changed. Now, why we should need an neoadjuvant therapy in the current era? Of course, it facilitates by shrinking the tumor from MRM to a breast conservation. It also risk prediction for the PCR, as the pathological CR has a connotations regarding the prognosis as well as the treatment implication. So, and the response adjusted therapy, as I said, the PCR connotes that you need to probably change to some other adjuvant strategy. So this is how the neoadjuvant therapy has evolved. And then the response evaluation. When we talk about response evaluation, when you administer the treatment, the marker of response can be clinical, pathological, molecular, and imaging. So there are various, the studies which are dealt on with respect to the treatment post neoadjuvant treatment. We have clinical radiological phenomena of CRPRS, DPD, and pathological by PCR and molecular by Ki67 and circulating tumor cells, imaging characteristics PET or PET MRI combination. The ultimate clinical outcome of these marker analysis is the local control, the disease-free survival, and the overall survival. So when you talk of HER2 positive or a triple negative subset, we need to know about pathological CR. So that's very important endpoint, as it is a surrogate of survival. So there are various guidelines which have postulated whether PCR would be a total, that is a stringent PCR, or it is a bPCR. So the guidelines that if there's an in situ carcinoma in the breast or in the node, so that's bPCR. And if it is a total PCR, which you call tpCR, where it is a YPT01 in situ N0. If it is everything negative as per the German breast group, which is a stringent PCR, where they don't consider even in situ there. So it should be completely negative. That is what we call it as the stringent PCR. So the pivotal neoadjuvant clinical trials in this particular setting. So to start with, this NOH study which was done both HER2 positive and HER2 negative. I will concentrate only on the HER2 positive subset in a stage 3 breast cancer, and they was divided as a small study for 250 patients, and they were divided into patients who have received the Trastuzumab and with an anthracycline, and followed by surgery without the Trastuzumab. So the outcome of this study is that the patients who received a Trastuzumab, there is significant increase in the PCR rate. If you can see here, the PCR rate is jumped from 26% to 65% in patients who have been treated with Trastuzumab. So that indicates that the PCR increases on adding Trastuzumab. So if you talk of EFS and OS, which is a surrogate of what the response is, and then you can see clearly a red bar suggesting a patient's receiving Trastuzumab, clearly benefiting with the trastuzumab, addition of trastuzumab over chemotherapy. So because it's a small study, there was a trend towards EFS and overall survival benefit with the addition of trastuzumab to chemotherapy in HER2 positive patients. So this was an addition of only one anti-HER2 therapy. Can you improve on this particular pathological CR? That's what the question asked. That's when the pertuzumab as a dual second anti-HER2 therapy was added to existing trastuzumab. So can you improve upon the pathological CR which was existing, which was to the tune of around 40%? Now the pertuzumab is one which has which adds to a HER2 signal and probably dimerizes. It just dimerizes with the other partners in the sense that it acts on the HER2 and then it helps in dimerizing with the other HER2 partners. So now we have data from dual anti-HER2 from NeoSphere study and TRYPHAENA. So first of all, covering the NeoSphere, which is a randomized multicenter open label phase 2 data in HER2 positive patients who have T2 to 3 and N0 to 1 and or inflammatory breast cancer. They should be chemo naive and the primary tumor should have been at least more than 2 centimeters. They were randomized to either receive TH, THP, HP or TP. So THP was pitted against all these regimens for a comparison, and the primary endpoint was PCR rate. That was the primary aim. If you can see the pathological complete response, their definition was T0, YP-T0, and in situ in the notes was also pathological CR. If you can see the green bar, which is 48.5% path CR in a THP group, so docetaxel, trastuzumab, and pertuzumab, and this was compared with others. So the interest was 29%, where it was only without pertuzumab. So there's definitely incremental benefit when you add pertuzumab to trastuzumab. When there is a 5-year follow-up data, PFS by total PCR rate. So all treatment arms combined in an intention to treat population. So tpCR was 85% versus 76% without the pertuzumab, which was with a hazard of 5, which was significant. So this was another one trial. Another trial is a phase 2 study of pertuzumab and trastuzumab in the neoadjuvant setting. Was FEC followed by docetaxel. So the pertuzumab trastuzumab combination FEC and followed by docetaxel. This is where they combined anthracycline together with the anti-HER2 therapy, which was not doing it. So then followed by trastuzumab for 1 year in early breast cancer. These were the primary endpoint. The safety as well as the tolerability was considered, and then the secondary endpoint was the PCR rate here. So if you see the PCR rate in the TRYPHAENA, so the green and the pink bar, if you can see, with that is with or without the pertuzumab. So there's some sort of 5% increment on addition of the TCHP. So if you can add P without P, so with the P definitely there is addition of 5% increment in the PCR rate. But if you subdivide them into hormone negative, hormone positive, there will be incremental benefit with addition of the PCR. So this is what I was just talking about. The PCR is stratified by the hormone receptor status. So in patients who are hormone positive, ERPR negative, and in patients who are ERPR positive, in that they just see the 83% patients have achieved a PCR rate. This was 79% without this thing, and then the FEC followed a pH versus TCHP remains the same. But if you compare these two with FEC followed by PHT, that's where the PCR rate is a bit less. So addition of pertuzumab definitely is adds on to the benefit. So there are other trials where sometimes a patient cannot take the chemotherapy with an anti-HER2 therapy. So what else we can offer? Can you offer dual anti-HER2 therapy without chemotherapy? Yes, you can do it, but the path CR is not that significant. So we have seen in NeoSphere the HER2 and Trastuzumab has resulted in only 16.8% of TCR rates, and that is very less in patients who are hormone positive. So also addition of lapatinib, trastuzumab, or lapatinib, any of these agents without chemotherapy, the PCR rate is less than 30%. So what is the correlate when you talk of pathological CR? As we say, it is a pathological. The CR is it correlates to the overall survival. To have any evidence for it, so there is an association of pathological CR rate with event-free survival in HER2 subtypes. So if we see this analysis, and if it's this analysis has shown, the pooled analysis of various studies have shown that the addition of the PathCR correlates with the survival that favors that there's a PathCR has a significant favorism towards the overall survival. So irrespective of hormone receptor status, so if patient achieves a PathCR, that is surrogate of overall survival. So again, reiterating a fact, the pool analysis from the Neoadjuvant, various Neoadjuvant trials, all patients HER2 positive and HER2 positive, HR positive, and HER2 positive, HR negative. In HR negative, the benefit is incremental. In a patient who are hormone positive, the benefit is not that robust, but still it's a significant. So patients who achieved PathCR had a better long-term outcome than those who had a residual disease, irrespective of the hormone status. So 3-year EFS also, if you can see, so EFS in patients who achieved PathCR by treatment modality. So the patients with the PathCR, so at 3 years, just wound up saying that the patients who had PathCR still had a higher risk of recurrence, and this risk was small in patients who received the PH followed by PH. So there's some data saying that would you do PH followed by PH, or we just do a PH followed by H? So there's some data saying that PH followed PH probably is better in terms of event-free survival at 3 years. We do it more commonly when the patient has high burden disease, there's node positivity upfront. So to summarize the pooled analysis from this, overall the patients who attained PathCR had a better long-term outcome. Some patients who had a PathCR still has a risk of recurrence. Therefore, the standard of care should be given in the adjuvant setting. And EFS appears to be highest in those patients whom we give PH followed by PH. So that's what the data suggest. And you can see the guidelines with respect to that. The patients who are HER2 positive, the preferred regimens are definitely the tchP. So we all definitely, as an institutional practice, patients who had more than 2 centimeter lesion, if you have to offer neoadjuvant, usually go for tchP. Very rare circumstances where the comorbidities and all the payroll, then probably you can go with the paclitaxel trastuzumab as a regimen. So that's it. A lot of us, we are following tchP as a regimen upfront. So with that, I conclude my talk. Thank you very much, Surgeon, and thank you everybody for giving me an opportunity to talk. Thank you very much.
Thank you, Dr. Chandu, so much for such lucid and very crisp talk. And I think that's what all these have been landmark trials that have shown the path to the progression of HER2 directed therapy. One question is that is there a better approach for hormone for like triple positive patients? Is there some new data where if intensification or some combination with hormones can make things better, or we still use tchP for our patients?
If you neoadjuvant, it has to be tchP, but the TDM1 plus fulvestrant doesn't result in that kind of a PathCR compared to tchP. So there the PathCR is up to the tune of around 40%, but if you tchP it goes beyond 50% even hormone positive. So I would still use tchP, but post 1 year addition of neratinib and hormone positive, that's what probably you take it into. But that was without TDM1 data. So in that context, tchP will definitely be enough.
So most clinicians end up using tchP.
Yeah.
Any specific setting where adding anthracyclines might benefit? Like
anthracycline, we have a recent data saying that adding an anthracycline may be a plus minus, but earlier we used to consider in patients who is hormone positive, HER2 positive, adding AC followed TH, where we used to do it because of to achieve more PathCR. But now recent data suggests that anthracycline may not be, add on to what tchP has.
Thank you so much again. And